G'day everybody, I'm here with Dr. Simon Davies and we've just been at the breakfast presentation where you've been talking about hemodynamic instability. Fascinating
Absolutely.
talk, thank you so much
My
for sharing
pleasure.
with us. I learned something new today. I actually didn't know what HPI was, so I wonder whether or not you might start by just giving a few take-home points about your talk and maybe sharing with people who don't know what HPI is.
Great.
That'd be great.
So HPI is quite a complex machine learning algorithm. It looks at features from the arterial waveform trace. And what it does basically is tells you the risk of you being hypertensive in the future. And it does it through quite a complex process, but essentially what you have is a number. And the higher that number is, the more likely to be hypertensive and the shorter the time to hypertension occurring. And we can use that clinically then, we can predict hypertension, we can intervene, treat the physiology so it doesn't happen again in the future. So quite innovation in terms of predictive technology being used at the bedside in the operating theatre, changing what we do to patients.
Amazing. And just on that note, I think one of the points that you made was that one of the differences that clinicians you observed was that the treatment was actually different when people used HPI. By interrogating the underlying physiology, people were using more inotropes rather than vasopressors.
That's right.
Talk us through a little bit about why
So-
you think that is.
We see a number of things at the moment, and by highlighting hypertension as a problem that leads to patient harm, we've kind of caused ourselves a problem. We're all starting vasopressors at the start of induction, and we're seeing that there's increased use of vasopressors, and giving a bit less fluid because of that is leading to more patient harm, mostly in terms of kidney injury, and also some gut injury. I showed some of those microcirculation pictures. So by using this kind of technology, by using different parameters, we let's call it balancing the circulation. Mike Scott coined that out of America, and just giving the right treatment to the right patient at the right time. I think that's what we all want to do inherently: treat our patient correctly and safely.
Wonderful. I loved how you showed us some beautiful electron microscope pictures of gut microscopy. That speaks to my undergrad. And I figured this is a really nice way to get more widespread engagement. So surgeons, if they're looking at gut microscopy, they're going to be on board with this type of change. Talk us through how you decided to use the microvilli as sort of, an example.
It was purely by accident. We came across this camera. So one of the colleagues who work with, Monty Myton, he's a professor at UCL or UCH in London, had an interest in many years ago in the microcirculation. He did some work on gastric perfusion, and we were doing these models, and he's going, I've got this camera, I'll bring it over from London with me. And it's like, great, Monty, we'll just try it out. And so we were doing these experiments, and it was sort of a bit of a wow moment when we saw we had all these normal numbers on our bedside monitor, but just no flow in our gastric circulation. And it was purely accident, just purely accident we came across that.
Yes.
Some of the best discoveries are, aren't they?
Really fascinating.
Yeah.
Hey. I'd love to take a moment to take you back to the York model and getting started in perioperative medicine and starting to sort of bring about change and bring in perioperative medicine as sort of a service. What advice have you got for people who are still, at the coalface in potentially regional areas, looking at starting up perioperative medicine and sort of enhancing a more comprehensive model for their patients? What were your biggest challenges and what tips might you have?
So the challenges were aplenty.
Yeah.
But even small changes make a big difference. So you don't have to have a comprehensive perioperative medicine service from the start. You just have to want to do it and to instigate some of those changes. And it depends. It's multifactorial, just from better pre-op assessments, from better patient expectation, through to good goal-directed therapy or hemodynamic therapy in the operating room. So using technology to patients' benefit, and then translating or transitioning that into the post-op period. And if there's one thing that we can probably do from a perioperative med service, see our patients the next day. If that's just the start, that actually makes a huge difference. Reviewing them, seeing them, checking they're okay. And perioperative medicine to me is just about doing all the simple things well. That's all the simple it is.
I saw on the York perioperative website that you have got a specific program for post-operative and enhanced nursing care where you're using this invasive monitoring and you're providing some really clear guidelines, but it's a nurse-led service. So I think that sounds like a really unique model, and tell us about the advantages and also the challenges of that.
So the advantage of it is that if you look at following a protocol, doctors are dreadful at doing that. We always think we know better, and we frequently don't. Whereas actually our nursing staff are really good at delivering protocolized care in a really accurate fashion. And the intervention it's relatively simplistic, but it is quite different for the nurses on the ward. So we set some basic parameter targets. If the patient goes outside of that, we just do a very simple passive leg raise. If stroke burden goes up, they get some fluid. If it doesn't go up, they get their vasopressor. We know that they're well filled. And once they've had more than 4 boluses or the vasopressor goes above a certain level, then it has to be reviewed by a doctor. And so I guess the biggest challenge was moving that almost critical care technology and treatment into a ward-based environment. And it was really training was the key aspect and the biggest challenge. But we've got some brilliant perioperative nurse specialists who spent months prior to this starting training the ward-based nurse about how to do this. And then just providing for those first few months just lots of support. We were on the phone 24 hours a day just in case, until they became comfortable and they became embedded within that. But I mean, it's been great for us. We've seen a reduction in length of stay. We've seen a reduction in the variability of length of stay as well from protocolizing care, and a reduction in complications too. So we're really pleased with the service, and the patients value it, the surgeons value it, and then we value it as anaesthetists as well.
And I think the other thing is just we've got this workforce shortage issue, which is never going to go away. So we need to start to think about problem solving that creatively, and how do we improve patient care whilst also taking that into consideration.
Yeah, very much so.
What are the next things for you? What's the next big question you'd like to answer?
Oh, well, that's good actually. I'm thinking about this on the plane on the way over. So one of my interests is exercise testing. Okay, so we exercise test our patients to try and determine the risk, but we don't know why exercise or poor exercise is related to poor outcomes. So we're currently looking at inflammatory responses to exercise, whether that maps to surgery and complications, or whether we can start to modify that inflammatory response through either increased exercise before surgery or through pharmacological mechanisms too.
Do you have any ideas about what the postulated mechanisms for that are?
So if you look at, I get really dull and nerdy here, I'm really sorry.
I love the nerd.
If you look at exercise, if you're really fit, you get a big rise in your interleukin 6 levels. But if you're fit, you do well from surgery.
Yeah.
But if you do poorly from surgery, you get a big rise in interleukin 6 levels.
Yeah.
So it doesn't quite make sense. So we're looking at the balance of the pro-inflammatory cytokines and chemokines, but with a focus on what's the anti-inflammatory mechanism behind that as well. So maybe people who are fit and have that big IL-6 rise also have a good anti-inflammatory response too. So that's what we're postulating.
And maybe cytokine preconditioning.
Very much so.
The physiologic response to that cytokine in exercise is going to be very different to the inflammatory response to surgery.
Very much so. So the first thing we're doing is mapping out the inflammatory response to surgery, and then seeing how those patients behave in terms of inflammation markers during the post-operative period as well, to see whether there's any correlations between those chemokines and cytokines.
Amazing, so fascinating. For those people who are really keen to learn more about the York model or the kind of work that you're doing, where can they find more information about what you're doing?
So if you Google York Hospital Preoperative Service, we've got our own website. It's got our protocols on there, our preoperative pathways, our intraoperative pathways, contact details for all my colleagues, our nurse specialists, and they're always happy to answer questions for anyone. And if you're in York, please come across to us, see us, visit our service. Always happy to have visitors.
Wonderful. Thank you so much for your time this morning. It's
Rosie,
been
thanks
really
so much.
great having a chat,
Great.
and I hope you all enjoyed that online.